So, dear colleagues, I will briefly share my experience on NCD investment case in part of the sources of data and data collection. And One Health tool here is one of the biggest issues when you collect the data for the business case. In this story, there can be two main sources of data. One of them is local country data, and another is the data from international sources. They have both of the data sources have advantages and disadvantages. Local country data are always the priority unless there is the big concern about the quality and validity. It can be, and I will also show some practical examples. Data from international sources, it can be country-specific data from the big international databases like WHO, or it can be some data, for example, from neighborhood countries. There are a lot of data which you need if you go through the full NCD investment case components, including the NCD burden analysis and One Health tool calculations. And some of them are rather easy to get in the country, some of them are much more difficult. Demographic, always available. Epidemiology data, it depends on the country and if there was step survey or local epidemiology surveys or not. Morbidity, in general, data is available, but there can be the problems with the age and sex distribution on groups. Mortality data, at least in the countries where I worked, was not a problem. Disability data, economic data, GDP, employment rates, and all things around these healthcare expenditures. Again, the total number are always available, but the splitting it into the groups per NCD group sometimes can be done only on the international experience. Then, population intervention and healthcare services coverage, I marked it by the red color because it's one of the major issues and major problem, and I will explain why. Cost, delivery channel, and so on. So it's a big amount of data. Where the data can be. Of course, one of the main sources is national statistic committees or something like that. Usually the country have such problem. Ministries and agencies, health, economy, finances, and so on, and some other sources. Here is the real example of Kyrgyzstan, where we did all the data collection on place by ourselves, and this is the number of ministries and agencies and so on which we contacted with during this mission with data collection. It's a rather big amount, and all these contacts needs time to explain what we need and in which exact format. So you see the big list. When you walk in the country, there can be some issues. For example, when you expect that data on disability are in the Ministry of Social Affairs, and then found that most of them are in reality Social Security Fund. This issue when you didn't have the morbidity data, incidence data distributed by age and sex group, and you have to find the way to do it using, for example, local registries data. And when you expect that, for example, the main investments in the population prevention intervention have to be inside the NCD action plan which exists in the country, but then found that it is not there, but in the...
Such a good presentation, so important. I'm just thinking that are people now starting to play with the tool? Because if they are,
you're all staring at your computers and you're all playing with your
then this is a really good talk, and therefore, all right, we'll do the article now, and we'll come back to this because of some really good stuff, and because you're drawing on real live examples from Kyrgyzstan. Let's hold this back. And
Nick, but the idea was that the people only pick up the files and he is listening.
That is right, but I don't think they are just picking up.
But when we will ask them to do it.
So let's ask them to do it. Okay, so in which case,
Unless they all close their computers and concentrate, it's not going to work.
But because Roger are now ready to start this
so in which case,
practical.
I think then I just want, what I'm really keen is that people pay attention to Anna because it's really good.
And nobody's paying attention.
So,
Yeah.
so what do we do? Can we now pay attention? Okay.
Let's hear from those in the room what they'd like.
What would you like to do?
We're not ready yet.
We can change the order. But
But it will be a waste of time because we still have to wait until the stick will go around all the table.
Okay.
Yeah.
Then in which case, all right, fine. So I just want you to listen to that.
Are you ready? Just to put the files on your computer, then listen me.
Yeah? Okay. All right, fine. Okay.
Okay, so it's just some real life example when you need some data but you're not able to get in the exact format or by either way. Difficulties of data collection by instrument. When we talk about NCD burden model, it's much more easier because it's mainly clear data from clear sources, demographic, mortality, morbidity, and so on. And from my 3 cases, we were able to get preliminary data during the first mission and collect them all on site and present the preliminary results on the last day of the missions. And the preliminary result was not much differ from the final one. For example, for Kyrgyzstan example, it was 4.2% of GDP as a preliminary and 3.9% of GDP as the final one. But when we talk about one hospital and data needed for it, in our case, we were not able to collect data on site to present something, to calculate something for each, because you see how big deal is this one hospital. There was a real big difficulties in understanding what data needed from the local teams. And in one from 3 cases, this data was not collected during several months, but we will have the second attempt to return and to try to do this. What is the major difficulties with One Health tool? This is the coverage and pin data with odds show. I will just show you, just think about these indicators from the point of view, for example, where you can get this data in Russia, knowing our Russian database. The coverage of people of the age groups, all of the age groups, some of the age groups, by follow-up for those at low risk of CVD and diabetes. Just think and try to say where in Russia you can find such data with the coverage. Some registers, some ideas where such indicators can be found.
Coverage with what?
Coverage of people with by follow-up care. This is lots of tricky things even in the formulation of these indicators. That's why in countries we sit, when you send out it, in all 3 cases, when you send out this list to the countries, they completely do not understand what you want from them. At least in our 3 cases. You come to the country, sit with the local team and explain them each point by each point, what it can be and where propose preliminary or possibly you can find such things. This is how it worked in our 3 cases of real life. Honestly, for me, I also do not know in Russia any source of data which can give good estimation of this indicator. Another one.
We have registries.
It's registries. We have several diabetic registries, but they include exactly this one.
No.
Yes. Yes, exactly about the preventive food care and neuropathy screening. Yes, I especially choose this one. And another one, from the population of tobacco, coverage of population by enforced use access restriction on tobacco. Of course, if it can be easy to, if it is existing, it's 100%, but if you need to estimate the level from 4, it's again. So, and
just with that example, can I ask a question? Is it translated into Russian?
yes, it was translated. It was fully translated
and
into
was
Russian.
it a good translation? Because I find in English I find that so difficult formulation that I can't even understand the English of that sentence, particularly the third one. And so I'm wondering how that was well translated into Russian.
It was translated by me personally, and again, in each case, we sit with each indicator, discussing it, clarifying it, and discussing where it can be. This is a major problem. It's just three examples from the long table which Odd showed you. So when you come to such countries as Kyrgyzstan, they really do not understand what you want from them, really. And as we all will work further in the low and middle income countries, all of those who will go to these missions will definitely meet this problem. In those. So, what will come out in the results of this, the most difficult part of data collection? It was expert opinion. In Kyrgyzstan, it was only mostly 100 expert opinion. Then the local team just visited the chief specialist of each area, chief specialist of cardiology, chief specialist of diabetology, and so on. And they just put some numbers. There were sometimes clinical protocol indicators, so the coverage was not the real coverage, but the number which is written in the clinical protocol. It is definitely not the same. And the only one case, then the local team really tried to connect these numbers with some evidence. It was Turkey, but I explained why they was one of the best in the data collection process. So in the end, for example, in Kyrgyzstan, you receive the table in which you see some numbers, but honestly, you understand that behind these numbers there is a very little evidence. But you have to use it because you do not have anything more. But it's rather a question again for us by ourselves. How reliable are results in the end if you use such input data? This is one of the problems with One Health tool. It's a really good tool, but to work it but in order to it was a good result which you receive with using this tool. You have to have a real good data, but this is a problem. What was the ideal, the proposed procedure of data collection? Preliminary request data forms sent to local country team, data spreadsheet, and preliminary data collected and the health economists receive it preliminary, work with them, and comes to the country, to the mission, just to clarify and to finalize calculations. I never was able to do by this way. James in Vietnam was able to do some distance things. Maybe he will share experience how he managed to do it, because for me it was not possible. And then finalizing calculation, final report, and mission to the country to present the results. How it works in real life. Preliminary request was sent in all 3 cases to all 3 country teams. No preliminary data collection was in reality. No data was sent to us in advance in 3 countries because they do not understand it. And the main issue was One Health tool data. inputs. So again, in all three cases, the first mission to the country was about explaining the data requests, about the data collection on site, and making some calculation. But it was difficult because in 4 or 5 days you have to do a real big job with a very little time to sleep. But we was able to make some preliminary presentation, and then there was needing additional missions to the country for data collections. For example, for Kyrgyzstan one, there were second missions needed to collect additional data exactly for One Health tool, and or for explanation and preliminary discussion of the results, and only then the finalization of final calculation, final report admission to the country. So for Kyrgyzstan, an example, this process takes more than 1 year, for example. The key factor of the success of data collection is out of the control, for example, of external consultant, definitely. It's the local team and its expertise, its willingness to work, and so on. One of the best team was definitely the Turkey team, because it was a very high-level expert from National Institute of Public Health. Who understood very well what we are talking about. But even in this case, for the staff of the Public Health Institute, it was need in coming and explaining the data we need for this, especially, again, going line by line with One Health tool requests. International data sources. If the local country-level data are not available, there are a number of international data sources. Firstly, of course, the WHO databases, 3 of them are linked here. European Health for All family of databases, which includes a rather big amount of data, which are country-specific. Mortality database, hospital morbidity database, and so on. If it includes some indicators exactly in the format which we need, but not all completely fit to the model. NCD database for European region, it's even more details, but it covers only this part of the world. There are some information on risk factors. World Bank database is a good source of data for some economic parameters, but in our 3 cases we were able to get this information locally because it's not so detailed information. There can be other international sources of data. Strengths of local data, of course, countries definitely trust more their own data. It's the major point. It can be obtained by local team in a rather short period if we have the good local team. And some data, they can be only local, and discovery data have to be local. And it's usually more recent. The international databases, including WHO, have the data usually 3 to 5 years ago and even more. But in country, of course, they are able to provide you the recent year data. Limitation of local data is reliability of some data, not the official statistics, but mainly some data on the coverage or epidemiology data. If the study was not so good, it can be the issue. But sometimes it's the only way to do. Strength of international data is, of course, easier access to it. It's just sitting in your office on your computer. It's cleared and verified data, for example, WHO data. But in this case, for example, if you will compare the WHO data on mortality with country data on mortality, they will differ, because WHO data are preceded, cleaned, and so on. But you have to remember it, that there will be differences. And possibility for international comparison if it is interesting to the country. Limitation of local data, limitation of international data, sorry, it's wrong headings here. They are not recent. The countries trust less. Not all data can be obtained in the exact format that you need for exact model. This my general points about data and my 3 countries' experience.
Thanks very much, Anna. Any comments or observations? James, you may have a few things that you'd like to add and complement to this.
Yeah.
Let's just get any questions or comments and then James can come in. Any comments or questions for Anna, please?
It's, I think that limitations, limits data is not the weakness of this tool, but it's the weakness of the problem on the whole. You can invent any tool for calculating the economic burden, but if you have no data, each tool will have this weakness. So it's not the characteristic of the method, of this particular method, but we really perhaps have to think how to motivate the health policymakers to collect data necessary for assessing economic burden and for forecasting the results. Maybe when we try to present the results of such calculations, maybe they can understand that it's useful to them. Because it's a real problem. How to motivate them to change the statistical surveillance and to get access, to give access to the data of insurance companies, for instance. Because we have a lot of data in insurance companies about the volumes of care, but nobody has access to it. It's closed. So it's the problem for each tool.
Thank you for your comments. I just wanted to also to answer on your comment that yes, but in these countries, when WHO and UNDP team comes, we really had good access to the existing data. We had the access to the health insurance fund data and so on. The main problem was that this data do not exist at all. This is the major point. And about the One Health tool, yes, it's a good instrument, but as the instrument is rather complex and have a lot of input data, it creates additional problems. More simple instrument, less assumption. More complicated instrument, a lot of input data, more assumptions.
Okay, thanks. Jill, do you want to take to the microphone?
Yes.
I think Anna's point actually summarised what I was going to say about the number of assumptions and things with the complexity of the tool. I mean, I have, as I've just said, concerns about the formulation. The English is very difficult. Anna, who understands obviously the Russian and the technical side, translated it and personally explained it, which was time-consuming. We assume high level of English in Turkey, but I'm not sure how much they fully understood the formulations because we didn't translate it into Turkish. And it may be the same for other countries where it's not in a language that's their first language. It's formulated around the best buys, which makes sense from my WHO public health point of view. But if I think of my own country, I would not know where to find that data. So if we think of 2 upper middle income, high income countries, we don't know where to find the data. So where are you finding the data in a low or middle income country? And how are you guiding them? And Anna's been working with us as a WHO consultant for well over a year now. Probably it's not 2 years, I can't remember, but she's now really, really familiar with WHO best buys, policies. She knows when to ask me something and when she's safe in understanding it. But if you are not in the room you people in the room are not familiar with those. You need to know what you know and what you don't know, in a way, and when to ask and when to make the assumptions. And I think for when we're thinking of sending people to collect the data, we have to understand the language of this data is so WHO speak that it's not immediately obvious. And I think the third point is just around the level of the number of assumptions that are made, and do we have a health warning in these reports? I mean, where it just kind of, these are the limitations of these findings, because we had to do the best we could during a year which was really piloting this approach in one of our countries, and we are anxious about different aspects of it, but we did the best we could with what we had.
Did you want to comment specifically on this as well?
Yeah, just really quickly. Outside viewpoint of someone who doesn't have to worry at all about using the tool, collecting the data, doing any of the real work. Just a couple of real examples of what you'll be facing. You need to know the tool. You need to be able to use it. You will use it, but it's not going to get you to the finish line. Inevitably, either before or at the last minute, the government will make a request, say, ooh, we'd really like a calculation on X issue. Next week, we go to Sri Lanka. In Sri Lanka, the governments have committed to phasing out completely tobacco cultivation by 2020. They want to know what that's going to do to their economy. That's not something that's easy to pull up on the One Health tool, but it's something that we have to present when we finish a week from today. We need to have some kind of numbers to show them. In Georgia, where we also did FCTC investment case, they are very keen to know what the impact of a complete ban on tobacco advertising would have on outdoor billboards. 80% of the billboards in Tbilisi are tobacco ads. Ending those, what does that do? How do look? They wanted numbers also in the hospitality industry because of the smoking ban in cafes. So these things that don't show up in the tool are likely to not just be necessary, but you may be requested during the mission. So it may be that on a Wednesday afternoon, the government asks for this, and we're expected by Friday morning to present it. So it's tough, but I think it's really good that we start with the One Health tool, but keep in the back of your mind that you're going to also need to be flexible, draw on the experiences you've had elsewhere and your knowledge from elsewhere. So this is the key part of the pie, but it's not the entire pie.
Okay.
Just a quick follow-on on that. We do form a network of people, and so don't also hesitate to call on your network and to use the network, because those kind of questions you're getting about tobacco cultivation, we could probably put you in touch with people who have thought through those kinds of things. That's a very interesting example.
Yeah, and as we do more, and then we get more and more parts of the tool. Like we were asked in Saudi Arabia to work on a costing for mental health. So we hope to have that as, maybe not as a set tool that you can pull off the shelf and plug in another country, but an example of where we've tried to grapple with the issue. Next week, I think in New York, there's a meeting with the Clean Cook Stoves Alliance who want to help build out a component of this work on indoor air pollution. So it could be that we end up with a modular component that can pull things in from there, and eventually we want to use road traffic accidents and just have more tools to draw on when we talk about this, using the One Health tool as the base and then complementing it with other things.
Thank you for your presentation. I think that in middle and income country there is the problem of intersector collaboration, and this problem appear when we want to collect data. We can have good collaboration with Ministry of Health team, but when we go with the other team from youth and sport and other department, we get such problem. I think that we should include the data sources, the data collection as part of the context analysis, because this will improve the quality of the data what we have already collect, and also it gives some insight of the the epidemiologic data and from where we get this one. And I think that also that we need to work with the country team on one health tool. They should be implicated with us, and thus they can help the team to finalize with the expert opinion, and also they will understand more what we need this kind of data, and also to explain what we say now, to explain what we need really, and the type of indicator. It's a good idea to enhance the collaboration of the country.
Okay, thanks. So Anna, do you want to reflect on that, or do you have anything you'd like to reflect, and James maybe as well? So, should we go? Let's. Why don't we have? Sorry, James. Why don't you go then, Odd, and then Anna can.
Yeah, I can speak a little bit about my experiences from Vietnam. You can imagine if collecting data in the country wasn't the simplest task, it was a bit more difficult doing it via Skype conversations and emails. Particularly this coverage point, which is crucial for estimating the impact and costing all our interventions. After several exchanges via email, it took a long set of paragraphs to ensure that they got the picture. But yeah, we eventually managed to get a hold of this data point. And so when we were doing the Vietnam case and the beginning of the Kyrgyzstan case, the spreadsheets that we were sending them for the data requirements were far larger than they needed to be. And since then, we've realized that we can cut it down to what are the essentials. And I think you have changed some spreadsheets. I know Brian, a guy working for RTI, has completely redone the spreadsheets, so we should be able to get a hold of these as well. And I think something else that we can do for the future is we can talk about this, but instead of sending these huge spreadsheets, two of the models that we're using, the Excel burden model and the NCD costing tool, these have sheets within these workbooks that send the data to the model. So what we can do is actually complete these models and send it to them rather than sending them empty Excel spreadsheets, because they'll just be looking at data and say, well, what's this for? We can actually send them the models and they can see using proxy baseline values, oh, this value affects this, like that's why we need that value. So then they can start with the proxy completed model and then complete it to improve the reliability of it. Yeah, that's all I can think of for now.
That's helpful. Thanks very much. Alexei, you wanted to add something?
Just in practical terms, when you're in a country, normally I think you will collect 80% of information from probably 20% of the counterparts and people you will be meeting there. And it's always quite important to identify, let's say, data champions. So, for example, James, while working with Vietnam, coordinated his efforts with the School of Public Health in Hanoi. So people have all the information in hand, and you can have one or two counterparts who has all the data. Same, for example, in Zambia, we have a Professor Gluma who collect all the information on public health in his institution. So it's quite important to quickly identify where the best data might be collected when you're in country.
The other thing that's probably just worth adding at the moment is that as part of the project which is being funded by the Russian Federation between UNDP and WHO with these 11 countries, we are employing a consultant who is familiar with the One Health tool, who is going to backstop people in the field. This person, his name is Rory Watts, has been identified, and he will have two roles. The first role is that he will be at the end of a computer a couple of times a day for specific technical questions that people have while out in the field. How do we do this? What am I to do with this? that builds on the network that Jeremy was talking on. You'll all have your networks with Anna and so on and so forth, but it does mean that you'll have somebody who will be dedicated and will be employed to provide that service. And the second thing they will do is then they will, if you like, quality assess the results on the report and to make sure that they are standardized between person A, who is in country Y, and person B, who's in country X, so that we then have some consistency across. So I hope that will assist in the process. Anna, do you want to reflect on what you've heard?
Yes. I agree with Alexei that if there is such institution of public health, it's a big deal. For Turkey, it was also the case, but in Kyrgyzstan, it was not the case. And in some countries, you will have to work with different counterparties in order to collect all data you need. Concerning these comments on different relations with ministers, it's also a very country-specific thing. For example, in Kyrgyzstan, all agencies and ministers were open for us and opened us all the data. But for Belarus, for example, it was not the case. So it's also there will be no standard situations. It will differ country by country, and we all have to be creative to find the right way. And the last point, Nick, is very good, because in my past experience, sometimes I waited with the answers on One Health tool for 2 months.
One other thing which maybe also just reflect on, and that's that there are times, there has been over the last year from time to time, the requirement for people in WHO to go back to the programmers who've been working on this. My understanding is that should be less frequent now because we've got it more or less sorted. However, there will be times when we may still need to go back to the programmers, and I think there is some agreement between WHO and the programmers to try and make this, make sure that when there are problems, they can be resolved. But I think it's just worth just telling people where we are on that, so that again they have the knowledge of what's going on in real time.
Okay. Maybe Jeremy, you know more about the relationship with Avenir and next sort of step with them on future NCD module development?
No, sorry. I mean, I can't offer any insight into that. I mean, you know, it's a relationship that we've developed over many years. We do get good level of responsiveness from them, but in terms of systems, procedures, how to access, I mean, the best thing would be to, well, I mean, at this point, I guess focalize that through me or through Odd to try to generate, you know, so it's like it's sort of a third level help desk function.
That's exactly that. Yes, I suppose really all I was trying to say was that people should not expect necessarily over the next year in all countries and all eventualities for us to run this through smoothly, and occasionally there may be the need to go back through WHO to your, as you described, third level support to the programmers to say, hang on, do we have a glitch or are we not using it correctly?
Yeah. So I mean, in that metaphor, I guess I don't know. Rory is first or second level help desk, and then
correct.
You know, some of us in Geneva, and then Avenir.
That's absolutely right. But I just wanted people to realise there were these different levels.
Yeah.
Okay.
Could you not formalise it, but could you do it as a cascade of first level, second level, contact details, peer support group, who, when, what, contact, so people are really clear.
I think that's not a bad idea, and maybe should be included in the guidance and the stuff that we're doing.
That sounds great. I mean, because you know, actually here we do now have a community of practice that does form a peer support group. So we've got that already, and then there's the first level, second level. So maybe just some thought about how to formalize that. Who are the contact people? Would be great.
And just in that community of practice issue, for WHO Europe, we always have to sort of have 2 peer reviewers on a report that we publish. And in terms of the quality control of the economics, if we can always have it clear who do we select to peer reviewers? Mm-hmm. What is the pool for that? Mm-hmm. And it might be when you're contracting people for these pieces of work, you've got a standing contract with Rory, and you give a day to somebody else to peer review properly what's gone on if we need to views on it.
Yeah, I think that's a good point. And there may, the person who can, the help desk function is not necessarily your peer review function. That's what
I'm saying. It's two things, and we need to. It's two things, and we need to contract for that possibly, and we need to know who we ask. The pool for the peer review, but if you just formalise it on a piece of paper.
So, out of interest, who were the peer reviewers for Kyrgyzstan?
We had Dan Chisholm was inside. We asked all the policy people to peer review the policy aspects. I went through everything, but we only had one health economist who peer reviewed because we couldn't get a.
That was Dan Chisholm.
So Dan Chisholm was the health economist who checked it.
All right.
So, I mean, you could put my name down as well.
Okay.
Okay, this is very helpful. Okay, so I think that's a useful additional thing that's come out of today, is in terms of strengthening for the guidance and the way that we move this forward, that we also include something along like that. And James is going to be taking the report that you had in front of you yesterday, the guidance note with those comments, and moving this forward over the next wee while to the next iteration. Then we'll get it finalised by colleagues in WHO before then making that a version that's available publicly, albeit it'll be updated, but at least that'll be where we are. Anna, anything? Lovely. Okay, thank you very much.